Nelson Mandela once said, education is the most powerful weapon which can be used, which we can use to change the world. And Sidney Harris said, the whole purpose of education is to turn mirrors into windows. Good morning, good afternoon, good evening. As per the time zone you're watching this video, today we have an eminent educationist, a professor and professor director and head of the department at Lady Harding Medical College, Pravesh Mehra ji with us in our virtual studio. आपका हमारे स्टूडियो में स्वागत है।
नमस्कार सुमन जी, नमस्कार।
नमस्कार सर जी।
थैंक यू सो मच सुमन, थैंक यू सो मच, गॉड ब्लेस यू।
थैंक यू सर, आप इतने प्रीशियस मोमेंट्स हमारे साथ आए हैं हमारे स्टूडेंट्स को सिखाने के लिए और हमारे व्यूअर्स के लिए। तो बताइए आप अभी कहाँ पे हैं? वेयर आर यू राइट नाउ?
मैं अभी रांची में हूँ और रांची में हम लोग फैमिली के साथ घूमने आए थे। तो मैं आपको दृश्य दिखाता हूँ जो मेरे पीछे में है। ये बोलते हैं इसको सरपेंटाइन रोड, जो पूरे हिल से नीचे तक जाती है। आप देख सकते होंगे ये टेढ़ी मेढ़ी रोड जा रही है हिल से, और उस तरफ मेरे लेफ्ट साइड पे अगर आप देख सकते हैं दूर, तो वो डैम है और बहुत अच्छी हवा चल रही है और गर्मी बिल्कुल नहीं है और ऐसे लग रहा है बारिश का मौसम बना हुआ है। तो जैसे सुमंत आप इट्स लाइक बीइंग विद नेचर, मैं बोलूंगा नेचर के साथ रहना शहरी आदमियों को, हम लोग को अच्छा लगता है। कमिंग बैक टू आवर रूट्स, इजंट इट? वी ऑल आर फ्रॉम दीस प्लेसेस ओनली। जाके तुम्हारे जैसे, अब तुम ठीक है बीच में यूके में थे, फिर कुवैत में हो, तो ऐसी जगह कहाँ मिलेगी जहाँ फ्रेश नेचर मिल सके, ताजी ताजी हवा आए। लेकिन
been a motivating force for me as well since beginning. Now, would you kindly like to guide and motivate our prospective students, citing your own journey from being a dental student to the professor and head of an elite college, Lady Harding Medical College?
ऐसा कुछ नहीं सुमन, हम लोग सिंपल आदमी है और कभी वैल्यू रखते हैं। वैल्यू ऑफ एजुकेशन, वैल्यू ऑफ हेल्थ, वैल्यू ऑफ आवर लाइफ इज वेरी इंपॉर्टेंट, और यही हमारे पेरेंट्स ने हमारे को दिया है। ठीक है, तो बचपन से ही जो था, कभी कुछ करने का तो शौक था, यस कुछ करना चाहते थे लाइफ में, और बीच में जब 11th में आए तो लगा नहीं मेडिसिन में आना चाहिए, हेल्थ केयर में जाना चाहिए, लोग की सेवा करनी चाहिए, बिकॉज हेल्थ इज ऑल अबाउट सर्विस, फर्स्ट इज सर्विस। और ठीक है वैसे आने चाहिए, देयर इज नो डाउट अबाउट इट, बट जो हम लोग जैसे लगते रहते हैं कि कुछ ना कुछ काम बिजी रखना चाहिए आदमी। बिजी ये है कि एक जो पुण्य काम है सर्विस में, जो पेशेंट के साथ हम करते रहते हैं, तो आइडिया वही होता है कि कुछ हम किसी को बेनिफिट दे सके, इसमें कोई दो राय नहीं। और अभी रिकॉर्डिंग हो रही, तो जैसे मैंने कहा था कि मेरी लाइफ की 11th में था, तो यस आई वांटेड टू डू मेडिसिन। देन व्हेन आई पास्ड माय 12th एंड आई गॉट द ऑप्शन ऑफ, जब वो नीट दे रहे थे, एग्जाम दे रहे थे, तो ऑप्शन था कि या तो मेडिसिन ले या डेंटिस्ट्री ले। तो मेडिसिन मिल रहा था, बट आई वाज गेटिंग इन, आई थिंक इट वाज इन असम दैट आई वाज गेटिंग। तो हमेशा था कि बॉर्न बाटा वेस्ट बंगाल में हुए थे, तो लगा कि नहीं आसपास कहीं मिलना चाहिए, तो दूर जाना नहीं ज्यादा घर से। तो जब ऑप्शन मिला कि हाँ डेंटिस्ट्री है, कलकत्ता में एक ओल्ड कॉलेज है बहुत पुराना, जो करीब 100 इयर्स ओल्ड कॉलेज है, और डेंटिस्ट्री इज अ न्यू ब्रांच, और इसमें जब हमें को पता चला कि एक सर्जरी ब्रांच भी होती है जिसको बोलते हैं मैक्सिलोफेशियल सर्जरी, तो हमें लगा कि नहीं लेट्स ट्राई इट आउट, व्हाई नॉट। और इसमें हमने को यही लगा कि जैसे अगर मेडिसिन में जाऊंगा तो मेरे को एटलीस्ट 15 साल लग जाएंगे, यूजी पीजी कुछ एमएस एमसीएच करने में, तब जाके मैं स्पेशलिस्ट बनूंगा। और यहाँ पे ऑप्शन था कि 6-7 साल में मैं स्पेशलाइज बन सकता हूँ, और न्यू लाइन ऑफ ट्रीटमेंट है। और जब वहां पे मिले, जो सीनियर से डॉक्टर शेखर चक्रवर्ती सर होते थे, डॉक्टर रोना पोद्दार थे, डॉक्टर तपस हमारे जो गाइड थे,
यस सर,
अच्छा, और लगा नहीं डेंटिस्ट्री में कुछ
सर नेटवर्क इश्यूज आ रहे हैं
ब्रांच ऑफ मेडिसिन, और विच इज ठीक है, एक बॉडी का पार्ट है, तो हम बॉडी का पार्ट अगर हम सिस्टम्स अप्रोच से लें तो अब समझ आता है कि क्या जरूरत है। उस समय उतना नहीं पता था, उस समय सब बोलते थे क्या डेंटल बनोगे।
You are breaking up, sir, बीच में।
अप्रोच कि आप अगर जैसे सिस्टम होता है, अगर मैं एक वॉच का लूं सिस्टम, इसी तरह ह्यूमन बॉडी एक सिस्टम है। तो वॉच जैसे है कि उसका सिस्टम का एक आउटपुट डिसाइड होता है कि कुछ आउटपुट चाहिए उससे। तो जैसे वॉच होता है, हमारे को एक आउटपुट चाहिए, टाइम, मिलने जुलने से सभी एक टाइम होता है। बट एग्जैक्टली अगर वॉच का 100% आउटपुट चाहिए तो एक एग्जैक्ट टाइम चाहिए, राइट टाइम चाहिए। अगर वो राइट टाइम घड़ी नहीं दिखा रही है तो सिस्टम का काम नहीं कर रहा है। इसी तरह अगर ओरल हेल्थ सिस्टम कि अगर वो मुंह नहीं खोल सकता, या उसको पेन है टूथ में, या उसको स्वेलिंग है, या बर्निंग सेंसेशन ओरल कैविटी में, तो ऑटोमेटिकली वो च्यू नहीं कर सकेगा, वो बात नहीं कर सकेगा, वो खा नहीं सकेगा, वो काफी काम नहीं कर सकेगा। जो टोटल बॉडी का सिस्टम है, एक 100% प्रोडक्टिव आउटपुट मिलेगा, वो नहीं मिलेगा। तो ऑटोमेटिकली ये हेल्थ केयर वेरी एसेंशियल है, एक पार्ट का। ठीक है, हम लोग उसको इम्पोर्टेंस नहीं देते, बट अगर दिया जाए तो इट्स अ बॉडी पार्ट। एंड जैसे अगर दांत नहीं होंगे, आप चबाएंगे नहीं, तो ऑटोमेटिकली योर स्टमक विल डू द वर्क। इफ यू कैन टॉक प्रॉपर्ली, योर पर्सनैलिटी विल नॉट बी देयर। सो दिस इज वेरी एसेंशियल इन लाइफ टू अंडरस्टैंड द क्वालिटी ऑफ केयर, कि आपकी क्वालिटी ऑफ केयर होनी चाहिए, क्वालिटी ऑफ लाइफ होना चाहिए। जब तक वो नहीं है, आई थिंक देयर इज नो पॉइंट ऑफ हैविंग लाइफ देयर। तो ये चीज सीखे बचपन से, और हुनर रहा करने का। और तुम्हारे साथ मिले हम लोग जाके, आई थिंक इट वाज द ईयर अराउंड 1997 if I remember, 98 when you were students, and we had just joined
Yes.
we had joined as residents there or demonstrators, and एक पार्ट था लाइफ का। एंड हमेशा ये रहा है कि टू गिव बैक टू द गवर्नमेंट समथिंग, टू गिव बैक टू सोसाइटी समथिंग, बिकॉज सोसाइटी एंड गवर्नमेंट हैज गिवन क्वाइट अ लॉट टू अस। आई थिंक मैंने कभी सोचा नहीं था कि इतना कुछ मिलेगा, एंड दैट इज व्हाई वी आर हियर नाउ एंड गिविंग बैक टू सोसाइटी व्हाटएवर वे वी कैन। यस यस
Abhi, now professor and head of an elite college, oral and maxillofacial surgeon, what are the challenges that come with this family life and your field of interest in maxillofacial surgery?
हाँ, तो देखो सुमन, ऐसे है कि when you join medicine line, any dentistry or medicine or whatever line you join, it is basically, I think money follows that. And you must have also realized that. And in this years of your growing up and the experience that you have world over, globally, tum ghume. So we realize if you can do some service, I think money is secondary. It's your main inner feeling of happiness, your fulfillness that you've done something at the back of the day. So family life of course is there. Abhi jaise family life enjoy kar raha hu. You see that area, I'm out of my surgeries, छुट्टी का दिन है, and this is the what life, quality of life is there. You work for 5 days and Saturday Sunday you enjoy, isn't it? भाई काम भी तो होना चाहिए, काम नहीं करोगे तो मजा क्या लाइफ में, isn't it? Money is not everything in life, and COVID has taught us money is never everything in life. It is basically the quality of life that is important. I don't require a 5-star food every day. I just require dal and roti, that is sufficient. But the quality is very important, to meet good people, to stay with your family, to enjoy nature, to be with God, to be spiritual. That is what is important, isn't it? And that is comes from your heart. Nobody can force you to do something, isn't it? So हम हमेशा ही करते हैं कि जब कुछ छुट्टी मिलती है तो ये छोटी चीज भी हो, अपने फ्रेंड के साथ बैठ के एंजॉय किया, अपनी फैमिली के साथ एंजॉय किया, आउटिंग हो गई एंजॉय किया, नेचर के साथ एंजॉय किया, एंड दैट इज व्हाट आई एंजॉय ऑलवेज मेक। पेशेंट जब रहते हैं तब भी एंजॉय करते हैं, ऐसी बात नहीं एंजॉय नहीं करते हैं। वी एंजॉय विद द पेशेंट्स आल्सो व्हाइल ट्रीटिंग देम, बीइंग विद देम, ओके, काउंसलिंग देम, making, creating awareness among them. We are doing that work. Surgery is a part of it. Okay, and when we get the response that yes, they have got good care and they respect you, तो सब पैसे उगड़ जाते हैं. You earn quite a bit of money from that. You don't require anything else. और हमेशा blessings होती हैं, तो patients की blessings होती हैं.
Talking about giving back to the society, giving back to the country. आपने जैसे बोला कि giving back to the society and doing a lot of charity works. So what policies can be implemented to improve the access of oral health care for those who are underserved population?
Yeah, so it depends actually where you are. Like in India, what we have done now is in the last, when I joined care services, I used to always go to the ministry and make an impression that what are we doing for dentistry there? And I didn't know how to go about it. Ultimately, in this some time, that I was in service, I could make the government aware that oral health care is very important, and what we can do. So ultimately, in that 20 years that I have been associated with the what I would say the government policies of the country and all, we've tried to do two things in a major way. One is we have tried to form a national oral health program for the country. The first time that has happened, and of course there are many people who are involved in this. But yes, it is always a joint effort. It's like a team effort happening, and a national program through which we could go on to various states. We could provide from the center quite a bit of funding to states, because you understand this in India. Health is a state subject. It is not a central subject. So it's a concurrent list or state list. So then automatically we gave the states the opportunity to come back with their PIPs, or what do they want, whether they want funds for creating infrastructure with a dental chair in a unit or something like that, or they already have a chair, they don't have a manpower, or they would like to have some materials, equipment. So funding was increased there. The second thing that was done was basically having 3-4 centers of excellence under the national work program. So like our center at Lady Medical College, you know about it, and we could develop a center of called a center for national resource center on oral health for potentially pre-malignant disorders, or oral potentially malignant disorders. Because what I understood was, and I made the impression in the ministry when we got that project under the Government of India funding, that what had happened was the idea was always creating a national center for pre-cancer became, because I was involved with the the cancer program in the country. So when you talk about the cancer program, the idea was to decrease mortality and morbidity. But whatever was happening in the cancer control program, whether we screening in an age group of 30 to 40 years, whether we providing diagnosis of cancer, whether we management of cancer, I think the mortality and morbidity of less than 80% or 70%. The steady was there between 70 to 90%. Morbidity was there between 79%. So we made, why are we going after cancer? We should target the pre-cancer which is lacking. And at this stage, as you know about it, we all read about potentially malignant disorders. So potentially malignant disorders are not cancer. It is basically a pre-cancer stage when the patient has no problem. But it's very important for a healthcare professional to diagnose that and to make the patient understand. Because once you can target it at an oral potentially malignant disorder stage, then automatically we can help that person to quit his risk, to counsel him, to idea being not to transform that oral potentially malignant disorder into a cancer, oral cancer. And if we can do that, I think we've done wonders. Now, who would do that? The idea was again floated that why not involve oral health professionals? Reason being, because oral health professionals read about quite a bit of soft tissue and hard tissue in the oral cavity. They are the main persons who can diagnose these oral potentially malignant disorders, because the patients visit them every 6 months. Could be for a simple extraction, for a filling, for a scaling, as we rightly say, that go back to a dental professional every 6 months or 1 year. And if we just motivate our colleagues from the oral health professionals to lesions and automatically report them and to do something add value to the patient's life, and we would catch these early cancers, I would say, at an early stage. At an early stage, would catch these lesions, which would transform into cancers if not diagnosed early. So the idea was that I sit in the chair and ask him to open his mouth. Without, you can't do any of the treatment. So once he opens his mouth, it is the advantage that as a healthcare professional he gets is that the patient just has to open his mouth and listen. He cannot talk much.
is a doctor or the medical professional, or professional who talks much, and the patient just has a chance to listen there. He can't talk because his mouth is open. And if you provide some amount of motivation to oral professionals, because they are motivated with the money factor into it. As a patient comes with a feeling, so they will feel better, right? But he doesn't get into it. So practices should change around. We should be more into counseling, into behavioral change, because you see, oral health is a part of the non-communicable diseases. And when you talk about diseases like diabetes, COPD, or CS, or cancer, or other conditions, we have common common risk factor determinant approach can be taken for oral health also. And when we made the ministry understand about it, I think then we got this project from ministry and we're working towards it in solving the issues that the country faces of having a 100% productive workforce, which is young. Because you see, cancer starts at 30 years, what I understand, but the oral potentially malady disorders always start at an early age. Because if you see the age at which a person starts tobacco, it's by the time he's in class 12 or passing out, as you know, we were all into that area. That is the time the adolescent, you're changing at risk, and the companies target you, as tobacco companies target you, so that once you get dependent on tobacco, it's very difficult to leave tobacco. So our idea is to target age group of 18 years to 30, 40 years, whichever group it is, which is taking tobacco in any form which is there. And this is the group where you get maximum oral potentially malady disorders. And if you can target them, we can provide some counseling, diagnose them, and start the management part of it at that level, which is not a major thing. I think we can help these fellows and help our country also by decreasing the mortality morbidity by more than 50%. So that's the basic idea, and we are trying to work on it. And I think this problem of smokeless tobacco, which basically causes whether oral submucous fibrosis or leukoplakia or orthoplakia or a part of lichen planus or some ulcers there, I think it's a major problem because the smokeless part of tobacco is mainly consumed in our part of the globe, that is the Southeast Asian region or the Asian subcontinent or the Indian subcontinent. It is not a problem of the global thing. It's not a problem of the Western countries or the Europe or the Americans. So they target tobacco, the smoking form of tobacco. Whereas my idea was never to target the smoking form of tobacco, the smokeless form of tobacco, which is a main concern in our country or our people. So I think we are working toward that, and I think you are a part of it. You are a stakeholder also in that program, and we will sit back. Yes, we have our deliverables to be met in a few years, and so let's see what happens. Yeah.
Thank you very much for the extensive coverage. Now, yeah, as you rightly, Professor Mehra ji, sir, as you rightly suggested, care providers.
So we are at one more place at the Midway Dine-In Resort. If you can see there, the Midway Dine-In Resort. So I'm there having a cup of tea, I'll have. Okay. And
so we are disturbing your...
so if you were there in India from Kuwait, I think we would have shared a cup of tea with you.
So sorry and thankful to you. You are sharing your dining time with us and our viewers. So as Professor Mehra Sarji just now said that oral health care providers are the first ones to diagnose a lot of oral manifestations of systemic diseases. So what is your...
Yeah, Bata, you're saying something. Sorry.
Yeah, as you rightly said, that oral health care providers are the first ones to diagnose a lot of oral manifestations of policymaker. What do you think we can do to improve coordination between oral health care providers and other healthcare providers?
You see, we have to integrate at some level. What I understand, there are two things, right? One is we have to motivate our colleagues that they should understand that as an oral professional, they are not medical professionals. That is number one thing. We should understand that. We are a specialist group of professionals which are called as oral health professionals, and we have a special target in mind to treat the oral cavity in the right way, because I understand any disease into the body maximum disease in the body will enter through the oral cavity. And we have seen the COVID virus also entering through the oral cavity only. And then we saw mucormycosis in a major way. So we are a special group of medical professionals, and we are not covered. You are also in Kuwait, you are in UK. We are not covered through the medical councils. We are covered through a different council, that is the dental councils. So we have to make our dental councils strong, first of all, because once we make our dental council strong, automatically we all will be strong as a subunit of that. And I admire our founder of dentistry in India, Dr. Rafi Ahmed sir, for the vision that he had. You know, when he came from the US, he was just a graduate of dentistry, and he had done his, I think, his post-graduation in I think prosthetics from there, and he worked at the fountain, one of the fountains, soda making factories in the US, in the Buffalo City. So he had that vision. He came here. Initially, dentistry, he didn't know what to do, because dentistry was always considered a quack that time in back again Kolkata or in India. The idea being it was 1915 or 14 that he came back. So he started a fountain at Park Circus, Park Street, and making the fountain soda factory there, and he started selling them. But ultimately, he wanted, his passion was into dentistry, and that all passion is there within us. So we should aim for, like you have a passion for doing something good for the betterment of profession, because ultimately we all are united in one thing, and that is dentistry or oral health, right? So he thought about that, and then when he became the Minister for Agriculture and all, he put in a proposal to the government that he wanted to start a dental college, and he cleared that. Then he formed the Indian Dental Association. Subsequently, he became the president of the IDA, and he then made the Dentist Act. So, Dentist Act came in 1949, before the Indian Constitution also came into being. Indian Constitution came into being in the year 1950. But this act of ours, Dentist Act, came in being in 1949. You imagine what vision he had. And that time, nobody knew about dentistry. It was always considered a quack thing. But getting a passed by the Parliament of India, it's a major thing. And during British time. Okay, so he got that passed. And the MCI Act came subsequently. It came in the year 1954. It was not before us, it was after us. So that vision was there. Then he formed the Dental Council of India. Okay, so he has done many things for us, I think. Major things. What he has done for us is unbelievable. And still, after around 75 years of our independence, we still follow the Dentist Act. And it is still relevant. Because he has mentioned, as a Dental Council of India Act, that a dentist oral professional will not only provide curative treatment, he'll provide treatment for health promotion, prevention, curative, reconstructive, rehabilitative. Okay, so all these are there in that act. See the vision that, and not only oral dental tissue. What he said was oral tissue that includes the teeth, tongue, lips, everything, including palates, including associated structures. Now, associated structures are many of them. You are taking a graft from somewhere, iliac crest. It is all because of a Dentist Act that I'm doing that. I'm taking a hair transplant. I'm doing that. It's just because of a Dentist Act, because it becomes an associated structure. You see, so that is a vision he had, and I really thank him for what he has done in my profession. The vision he had for that, and so we also should contribute in some way. I don't think I can contribute a very major way, but yes, at least some way to our profession. And I think if we can do that, so doing that in India, the first I was talking about, we have formed a national oral program. Now we are coming out with the first time in the country, a national oral health policy. So in the first time out of 75 years of independence, we will have a national oral health policy for the country, right? So these are major things happening. And then we have this resource centers coming up. So we have 4 resource centers in the country now, but subsequently they'll be expanded to much more. We will have centers of excellence coming in the field of oral health, in the field of oral health research. Okay, so these will be good things happening in the country. We already have around 300 plus dental colleges in the country. We already had roughly around you can say 10 lakh registered dental surgeons in the country. So we will be the global factory for providing oral health professionals around the globe. The maximum dental surgeons are passing around the globe, so India. But only thing what we require now is providing a quality care. You see, a quality care and providing quality education. That is a challenge now in our country, where we are trying to do that. It's not easy to provide that type of quality care because we are a third world country. Resources are limited. I understand. Patients, there is no doubt about it. There is no dearth of patients in India. Every dental college has had to support satellite clinics down to the villages, okay, down to the last person that we can serve. Because what idea in the national oral policy is also to provide accessible and affordable and a quality oral health care to our masses, to our population. And who will be there are underserved populations or the population in tribal areas or basically marginalized groups or special category people. So these are the main things which we will think about providing oral health. And I think we are in the right direction. And the only thing that is left now is some have already post for oral professionals in CSCs or the CSCs, district hospitals are mandatory to have at least 5 dental professionals wish list. And similarly, the NMC, National Medical Commission, also come out with that you should have at least 3 or 4 dental professionals specialized there to providing specialized services in the community, in that college there. And subsequently, I think the central government leading there, what we require now is a directorate in each state. So each state should have a director of health services, oral health services, I would say, not health services, it's already there. So oral health services would be there, where the manpower oral health, which is in that state, would be under the directorate of oral health services for that state. And similarly, in the central government also, it is not there now, but yes, the vision is to provide a directorate of oral health services under director of health services. And of course, once we have a higher up H officer in the oral health services category, I think our manpower or our motivation or manpower who's working under him would be much higher. Because now we can say we are equal to, we are not less than any medical profession in the country. And already the courts have given the judgment. There have been time and again cases there. And in my case also, I suffered that. When I joined Lady Harding, I remember a person telling me, a very higher person in the ministry telling me that you are not a medical professional. I told him, I said, look, I am not a medical professional. I don't want to become a medical professional, because for that to become a medical professional, I have to be registered under the MCI Act, which I don't want to. I am registered under the DCI Act. Only thing I want is whatever benefits a medical professional gets, the similar benefits an oral health professional should also get, depending upon what post he's doing, similar to what post he's holding with a medical one, because he's carrying out similar process. And you will be surprised. Person told me that, Doctor Sahab, you are treating a tissue. So I told him, if I'm treating a dental tissue, that tissue is still live. And medical professionals are there, specialists are there, who are only treating dead bodies or only treating blood samples. They are not doing any night duties. I am doing a night duty. I am doing an ICU treatment. I am doing a surgery. I am doing an OPD, IPD, 24/7 trauma care. I am doing. Who less is there? I'm not doing any lesser treatment than a medical colleague. You name one. So then he subsequently realized that, and he said, Doctor, I'm sorry. I said, don't tell bad about my profession. You tell me everything, I'll withstand, but never for my profession, because we are meant for serving the patients. Like a medical professionals, we want to serve our patients. And what is the harm that I have done? I have not done any harm. You have a council act which says the dental council will register only oral professionals. A medical council will register medical professionals. That's not my care. It's a policy making of the government. So once you've taken that out, my idea is only if two people are serving one human body, as I said, about systems approach to you. So why not keep these both hands in the same way? Treat them equally. And now you'll be surprised after this 20 years with the legal system and getting out. I think all the oral professionals under the Ministry of Health of the Government of India are getting an equal pay, equal rank, every facility which a medical professional gets. Otherwise, there was discrimination. There was a lot of discrimination because there were issues there. There is no doubt. So we said, why not? You make our course 4.5 years course. So now the Dental Council of India has recently come up with the ministry and said, yes, a dental course, a BDS course should be 4.5 years. He should have 1 year internship. He should have 3 years of PG as a medical professional does. So there is no, yes, you give us something we want to do. There is no doubt about it. We want to, yes.
Yes, sir. So thank you very much for letting our viewers know about various issues, our students, and the various protocols you follow, and as a policy maker, and also to our patients. Now, two questions combined in one. How can you explain the benefits of Pradhan Mantri Jan Arogya Yojana and Ayushman Bharat scheme for the oral surgery patients or oral surgical procedures?
Thank you, Sumant. I think question was very relevant because ये मैंने देखा अपने लाइफ में जो अपनी practice हमने किया करीब 30-35 years of practice सब तक मैं कर रहा था. The problem was not in the middle class or the high class that had oral diseases. Okay, the problem was with the underserved areas or the marginalized areas.
Yes, sir.
So these fellows used to come to us. Okay, suppose he comes with a tumor in his mandible or maxilla or a trauma, multiple fractures of the face. I think ये जो हमारे पास आते थे in the government sector.
Yes, sir.
And to some of the private sector also government से इलाज नहीं होता था. They had to sell almost everything, to sell their house. They had to sell their utensils, their jewelry, everything. Because health is very important. Okay. Everybody wants a good health. So, जब इनको देखा तो really tears आते थे. And that time, the insurance was basically in a private sector where you give some money and you get an insurance done. In the government sector, insurance was only limited to, could be employees or for that matter, could be in the army, where people are serving ESI, laborers, but not to the general public who are marginalized. Then our Pradhan Mantri, Narendra Modi ji, had a vision to give something back to the community. I think that is a vision that came out with a quality healthcare to the marginalized people who are there. Because automatically when you provide some insurance in healthcare, your expenditure decreases. It's all a question of economic to scales, right? Because one person might have the health issues. If you cover 100 people, automatically your amount comes down and the government saves on that. So the idea of providing PMJY came into being, and then subsequently you had something on oral health also where we contributed. I think now you'll be happy to know that under the Government of India PMJY scheme, you have around 19 or 20 maxillofacial surgical procedures covered. Okay, so any person who's got that card of PMJY, of course, it's a scheme which you must understand is both the central government and state government scheme. As I said, health is a state subject, not a central subject. But the central ministry contributes around 70% and the state government contributes 30%. So some states have it, some states don't have it. Some states go in for their schemes depending upon their conditions. But the beauty for this scheme is that any of this person from the marginalized section who has a health card of PMJY, he could go into any government healthcare facility or private healthcare facility where this scheme is lagu, okay, or where it is recognized, and he doesn't have to pay a single money for it. Okay, from his medicine to his investigations to his indoor treatment to his ICU if it requires, to his follow-up, everything is covered in that. And since I'm in the government sector, the advantage with us was that you see, when a patient used to come to me, some area of concern was sometimes some medicine is not there, some surgical instrument is not there, or equipment which I have to use on this patient is not available. So with the scheme was paying back to the government something. Okay, so when they pay back to the government, they want everything free, right? So it was essential that whatever instruments, materials, or equipments I require for treating that patient, that was supposed to be given by my administrator, by my additional MS, free of charge, and immediately. So as the patient comes in, if I just produce one a card of his, and I have to admit this patient, and I give a requirements invoice or whatever equipments, instruments are required, everything is provided to me immediately within a period of 24 hours, so I can perform the surgery, don't delay it, and everything the patient requires. So that is the beauty of this scheme. And of course, at the end of it, provides the three things I was talking about. It makes the healthcare accessible, affordable, and quality healthcare is given. And I think you would be happy to know it's one of the schemes of the government which is internationally recognized now. Like you have the NHS, the UK government, you've seen them. Similarly, India has a scheme of CGHS for its employees, but targeting a marginalized group. Of course, PM is the answer. And ultimately, what I see, the vision of the Prime Minister, I think he'll merge all the insurance schemes into one. What my idea is, that would come in. Because you see, whenever a person accesses healthcare facilities, as you talk about the equality of care, so Article 14 comes in. Why should the care be different to a person who is of a higher strata or lower strata? Like in the UK, it is same, right? So similarly, the equity of care also should be similar. I think if we can have that vision and provide treatment on that pattern of equity of care, I think we made quality accessible to our countrymen all over India. I think that's the beauty of this scheme. Yeah.
So again, talking about you as a policy maker.
I'm at a resort. You see the children playing there, and that's the boats that are there. So we will be on one of the boats there, as you see. Okay, and let's go for a ride. So okay. So we are enjoying here, and that is the beauty of, as you said, your work-life balance should be there, isn't it? So you work at the same time.
We'll let you enjoy.
Your friends, everybody. Enjoying with you also. Yeah. Thank you so much. We're enjoying with you in this class. I'm with the family. I'm enjoying here. तो तुम तो दिल से हो ना भाईजान वैसी बात है.
What is your short and sweet final message to our viewers, please?
I think do good, stay good, and have faith in God, and enjoy life. I think we have very few years of life that is there, but enjoy that. Have a quality of life and give something back to the community from where you come. I think if you've done that, you've made your day.
Thank you very much for the nice discourse and for nice enlightenment on this topic as a mentor, as a policymaker, as an educationist. Thank you, sir. We'll be in touch with you and hope you have a pleasant stay there and enjoy your family time. Thank you very much. Thank you.
Bye-bye, Sumant.
Bye-bye, sir. Bye-bye.
Dr. Bhaiya, namaskar. जब दिल्ली आएंगे तो मिलेंगे जरूर. ठीक है? Keep in touch.
Sure, sir.
Bye. Take care.
Yes, sir. We'll be in touch. Namaste.